Today we're joined by Professor Dina Zur, Director of the Center for Retinal Degenerations at Tel Aviv Sourasky Medical Center and Associate Professor of Clinical Ophthalmology at Tel Aviv University. She founded the Retina Research Center and has authored over 90 peer-reviewed publications in medical retina, imaging, and inherited retinal diseases. She's a recipient of the Science Award by Tel Aviv University. She is chair of the Israeli Retina Society, serves on the ARVO Israel board, and is part of the Uretina Subspecialty Committee for Retinal Vascular Diseases. Please subscribe and enjoy.
Professor Dina Zur, thank you very much for joining me today. It's a truly honor, always. I'm so delighted to see you and so happy to see you and talk with you. For me, it's just amazing to keep learning from you. Besides that, I finished my fellowship more than almost 4 years ago. Being far away and keep learning from you, for me, it's just an honor. So our goal with this conversation is to help the audience, especially young retina specialists, to recognize the spectrum of pachychoroid diseases. So this we'll try to do it in the next 30 minutes. So with that, let's begin. Once again, thank you very much for being here with me today. I really appreciate the time.
Thank you for the invitation. It's my pleasure. And I'm also happy to talk about the specific topic, which you know that I like it very much.
I know that you're an expert on this, so you're the better that will guide us on this adventure. So to start with the basics, how would you define the term pachychoroid and what distinguishes it from the normal choroid for, let's say, in a patient?
This is a good question. It seems like an easy question, but it's not, because there's still a lot of debate ongoing. What is a pachychoroid? Because pachy means thickened, but as you all probably know, there's not one number that makes it thickened. So usually we talk about that the thickness of the choroid. If you just take the caliper and measure it on the OCT, it should be more or less as thick as the retina. So if you have a very thin retina and a much thicker choroid, you might suspect that there's thickening, and the other way around. Now, there are normal states where the choroid is higher in number, as you might see in most of the people, like in patients with hyperopic eyes, for example. It's not a pathological state. It's part of the structure of the normal eye. On the other hand, if we see that some vessels within the choroid are thickened and some others are compressed, this makes it a pathological condition. So we not only look at the thickness of the choroid as an absolute number, but also on the inner structure. And what we want to see is that there's no compression of the choriocapillaris. When you see thickened vessels that cause compression, then it starts being something pathological.
Okay, great. And do you see the pachychoroid as a disease continuum or more as a group of distinct entities? For example, the CSCR, the PCV, all of these diseases can be grouped as a disease continuum, or each one is between the pachychoroid spectrum, a different entity?
First of all, our understanding what the pachychoroid spectrum is has emerged a lot during the last, I would say, 2 last decades because of the advanced imaging that is now available. So we know much more just because we can images and we can visualize the changes. And we do know that there are patients that evolve within the spectrum. So they start with an acute CSC and then over time develop chronic changes. They develop neovascularization due to the chronic state. They then also can develop a polypoidal component of the MNV. On the other hand, there are patients that only have, let's say, pachychoroid pigment epitheliopathy, and they stay within this state for a long time. But probably we will not find a patient with chronic changes that has not gone through other stages. We have just seen him much later within the course of the disease.
Of course. And which of these diseases will you point as the main ones to identify, or the most common ones to group in the pachychoroid disease spectrum?
The most common one is central serous chorioretinopathy. If you look at the absolute numbers, it's the fourth most common maculopathy after AMD, DME, RVO. Then comes CSC, and I'm sure that all of you frequently see those cases. The majority goes resolve spontaneously, and then are about 1/3 of patients that have chronic recurrent disease or even develop chronic changes. And the other conditions, I think with more imaging, we now are more aware of things that also have an underlying pachychoroid etiology, let's say. For example, pigment epitheliopathy is a very common thing. So if you for the audience, if you have, let's see, a patient with only pigment epithelial detachment, a younger one, so no AMD in the image, of course, and you do autofluorescence and you don't have any evidence that there was previous subretinal fluid, it's only a pigment epitheliopathy due to pachychoroid as an underlying status, and this is also something which is not rare at all.
Yeah, we need to be aware that exists to know that we can diagnose it. That's why I want to do this episode, because there are many parts of the pachychoroidal spectrum diseases that is not only central serous chorioretinopathy. There are much other spectrums that needs to be, with the finger on to think that exist and diagnose the disease. PCV, it's part of the pachychoroidal spectrum disease, or it's more kind of a age macular degeneration spectrum disease? What do you think about this?
So, Polypoidal choroidal vasculopathy, PCV, it's something that you can find below different etiologies. So, of course, we have patients with neovascular AMD, and they do have polypoidal lesions. This is one thing. But if we talk about patients that have no evidence of AMD, they are either younger, there are no drusen, etc., then you can find PCV, let's say in Asian people, it's more common, but we also see it in Caucasians, which can be a standalone condition. But there's quite a number of patients that have underlying pachychoroid. So if you want to image this, you should do an OCT which shows you properly the choroid. So either use enhanced depth imaging if you have spectral domain OCT, or if you have swept source, then you will visualize the choroid quite easily. And you really need to see if below the PCV you can find enlarged choroidal vessels, mostly also compression of the choriocapillaris, and frequently next to the polyp you can see a flat irregular PED. And this actually should raise the suspicion that this is the condition. There might be people that would say that it's a bit semantic to go into those details, because if you have an exudative state with PCV, the treatment will be, of course, anti-VEGF therapy, but the prognosis is quite different if you look at patients with neovascular AMD or this one.
Of course, and there is a new one that, not new one, but a recent one, more study, that is the peripapillary pachychoroid disease, right? Which I saw one of your works, which is amazing. And this is also part of the spectrum of pachychoroidal diseases or pachychoroid diseases that can affect also the macula, right? Like in an exudative manner.
Yeah, correct. Okay. I think this is also something that was underdiagnosed in the past. It's like a new entity, but the condition, of course, is not new. So it affects mainly elderly men, different from the CSD, which we see mainly in young male patients. And it is for itself a spectrum, because there can be patients that will have only some intraretinal cystoid changes next to the disc. The macula itself is almost not involved. The vision will be good. And only if you image it, you will see it. But then are cases that are really severe and very hard to treat, where you have those cystic, chronic, degenerative changes that could involve the fovea. They can really cause atrophic lesions. I have patients that have very low visual acuity due to this, mostly bilateral, but it can be asymmetric. And the problem is that there's no real consensus on how to treat those patients. So many have tried anti-VEGF therapy, and you will find some reports that mainly aflibercept maybe could be helpful. But then again, we have patients that are really not responsive at all to injections. And we did a study together with my colleague Claudio Iovino from Italy, where we looked at patients that underwent photodynamic therapy for peripapillary pachychoroid disease, only if they had a lesion on ICG, which was with late hyperfluorescence so that you can really spot during therapy. And we did find that it was effective to resolve the fluid, mainly the subretinal, but also the intraretinal fluid. The problem is that it can recur after a couple of months. So those are really tough cases to manage.
Yeah, but very interesting one. Which imaging, talking about essential multimodal imaging in this spectrum, would you consider? You have a patient for young retina specialists that they receive a patient, for example, with choroidal central serous chorioretinopathy, and which imaging would you recommend to request to that patient? Like the follow-up, like AVC. This imaging is essential for this patient.
I think the first thing that we all need to do is, of course, an OCT. And again, it needs to visualize the choroid efficiently. And the OCT, on one hand, serves us to understand where the fluid is, to make sure that there's a choroid that explains the condition. And of course, to see that there's nothing else, there's nothing that you have to suspect, the neovascularization, etc., in addition to the clinical examination. And I don't demand angiography at the first visit of an acute young patient with central serous chorioretinopathy. I do see them after 2 months, up to 2 months for the second visit. And if at that point I see that he's in the stage of resolving the fluid, I would only follow him with an OCT. But if after, let's say, 2 months, there's no improvement at all, or even worsening, I do recommend to do fluorescein angiography because it can help you to plan ahead and see that if the patient will develop non-resolving fluid, on how you can resolve the leakage as soon as possible.
Okay, and I will send a little bit more about the central serous chorioretinopathy because it's one of the biggest dilemmas of this year in Mexico of how to treat and manage these patients. So we know that the gold standard therapy for these conditions is photodynamic therapy. But nowadays we have experimented a lot of shortage of vertepofrin for treating these patients, and honestly, in Mexico we don't have it. We used to have it very commonly, even to treat in the past, age macular degeneration, but now we have lost this opportunity. So, what do you recommend, or what do you see about other approaches that we can consider treating patients with CSCR? And as you mentioned, you have a patient that is young, that is the first time that he or she presented this fluid under the macula, and you request the OCT, and it looks by the book. It's central serous chorioretinopathy. Would you advise to consider, you don't advise to treat until the next 2 months, right? Just follow up, because the majority of these cases will resolve spontaneously. So my dilemma here is many times here in Mexico especially, there are some groups of retina specialists that advocate to inject anti-VEGF from the first visit, because they pledge that it's fluid under the retina and that fluid is not okay. So it will be toxic, and as sooner we treat this patient, the better, right? As sooner that we resolve the fluid, it will be better. So what do you think about this approach that deciding inject this patient with anti-VEGF?
First of all, we had the same situation with the shortage of Visodan. I think it was a global problem, and still parts of the world are unfortunately still affected, and I hope it will resolve sooner. When we talk about intravitreal injections of anti-VEGF, we target vascular endothelial growth factor. Now, in central serous chorioretinopathy, there is no upregulation of VEGF. So if you inject those patients, there is no rationale that in an acute CSC case, the injection would resolve the fluid. I'm not talking about a complicated case with neovascularization or even suspected. That's another story. But if you pledge to inject anti-VEGF, I think you have to have evidence that there is neovascularization. You can see it on OCT angiography. You can try to visualize it sometimes on the ICG, maybe a bit harder in those cases, but I don't think that there's evidence to inject. Even more, all the studies on CSR are problematic, not all of them, but most of them, because they don't have a control group. So even if you will find a case report or some small study saying that this is effective, we all know that at least 2/3 of cases, if not more, will resolve spontaneously from the first episode. So most of those cases probably would have resolved even if the doctor would not have given the injection.
Yeah.
And of course, everything we do, there's a small, tiny chance of endophthalmitis, so we have to keep this in mind.
Of course, the risk besides benefits in these cases, right? And I have seen
Definitely.
in some of these patients, because sometimes I receive patients that were treated in another clinic, and the patient comes to my office and they telling me the doctor in the other office inject me, and he told me that the fluid resolves because of the anti-VEGF, but my vision still's quite the same. I mean, I didn't feel the proof, like magnificent improvement in my vision. And I have compared in my clinic some patients that have been injected in another clinics and patients that I just follow up, because that's what I learned with you and with all my mentors in my fellowship. And after I follow these patients, I realized that when fluid goes by itself, the final visual acuity or the best corrected visual acuity is exactly the same, comparing the patient that will inject to resolve the fluid. So I think that is not even a rationale to inject these patients, because the visual acuity will be the same if you just left them go by and wait just a few months to resolve the fluid, right? That's what I saw. Maybe I'm not right, but that's what I have seen in my practice. It's more complicated to follow the patients, more in a more protocolized way here in Mexico, because we have different situations. But I have seen this in my daily practice. Do you see that too in your clinic?
So, first of all, I do agree that, again, if we talk about an acute case, it's completely legit to follow them. There are some conditions where you might urge the treatment if it's the better seeing eye of a patient, or if you already have evidence of damage to the photoreceptor. So the patient, even he didn't notice, he definitely had previous events of CSC, and you do see that there's already thinning of the outer nuclear of the ellipsoid zone. Those are cases that I would be reluctant to wait for a long time until the fluid will resolve probably on its own. And then if we decide that the patient needs treatment for whatever reason now, it's mandatory to have angiography. So either fluorescent angiography if it's an eye that did not have previous major events and you don't see widespread RPE changes. I think it's good enough in most of the cases to plan for treatment. Or endocyanine green angiography, ICGA, which of course gives us a lot of information about the underlying choroid where the disease actually origins. A lot of cases we were able to do focal thermal laser during the shortage of PDT. I think it's a valuable option, and it's one that has been investigated and it's effective. Of course, in cases that are far away from the fovea, so you can treat safely. And if the leakage spot is not too large, because you cannot cover a wide area with thermal laser, you might then really set the patient at risk to develop neovascularization later on. But otherwise, I think it's one of the most available and pricey options also for the system.
Right. And when you do this focal laser, which parameters you recommend? You use the argon laser, like the regular one?
Yeah, I do. I think it's very important to see the early frames of the angiography, because if you look after 3 minutes, let's say, the leakage has already spread and will cover the original leakage point, which is usually very small. So you really have to go through the early frames and to see where this leakage comes from. And then use the vessels to plan for the landmarks, so you can spot the area you want to treat. I start with the tiniest spot I can use. In our case, it's 50 micron. and I use the smallest amount of energy available on the machine. It's mostly about 60 millivolts, something like this.
Okay.
And then you raise it gradually until you see some whitening, not more than this. You don't need to like get it chalk white like with a PRP.
Yeah. Okay.
That's usually enough.
And once you do the laser, how long you wait to request another OCT, for example, to see if it's working
6
or
weeks.
not working? 6 weeks. And only OCT,
and
not fluorescein angiography.
Only OCT. And
Okay.
I always tell the patient in advance that he should not wait, to see any difference within some days. It takes time. And I think one of the most important things in CSC specifically is to communicate with to the patient that when there was fluid, even for some months, usually they will have some impairment of the visual quality, not the visual acuity. If it might be visual color, the color vision, or other things that they are very, very sensitive to, because they will always think otherwise that the treatment did not work. So it's hard to communicate that even the fluid goes away, and we did the best we could, and it was a success. The fluid has resolved. They are frequently not happy with their vision.
Of course, yeah. And what about micropulse laser? Have you ever tried it? Do you think it's also a good alternative, especially in these cases where you see the leakage that it's really subfoveal? You cannot do focal laser in these cases. So what other alternatives do you recommend? Micropulse laser then?
Those are really the challenging cases if you don't have PDT available. So the PLACE trial, which was the only randomized trial that really looked at the questioned PDT or micropulse, they found that PDT was the gold standard, as you said before, so it's the most effective choice. But it seems like micropulse does have a place, so I have colleagues that use it, and they do see success with it. There are some questions on how to do the titration of the energy levels. But I think in the absence of PDT, it's a valuable option if you cannot do the focal laser, because all the pharmacological treatments that were tried, unfortunately, have failed to show any efficacy, and they're not free of complications. So I'd rather go for micropulse laser than trying systemic therapy on patients that did not have shown any evidence in the literature of being effective.
Yeah, but at least you're trying something, right?
Yes, completely.
Yeah. Which systemic therapies will you advise to, or you will consider? I mean, I know that there haven't been enough evidence that really works. Mm-hmm. So, but in case, you have these cases, and sometimes I think the patients feel more stressed because you're not doing anything. And you just tell them, we can do anything. Just follow you up in the next few months and see if it's resolved. But what would you advise in these cases? Which systemic therapy would you consider?
So if the patients frequently come in after they have read online a lot of things or in some groups. So aspirin really doesn't have any place in the treatment. First of all, I think patients need to know this. Okay. Then the question of Plerinon, yes or no. The Vichy trial really looked into it and didn't show any evidence of it. We also have patients where, we were out of Visodine and the patient was getting worse. And we do have some that did better after treatment. And again, it's hard to prove that this is a causal relationship. But I do think that it's not a mistake to try it in severe cases. But explain to the patient also what are the complications. He needs to check his electrolytes time to time.
Yeah.
But it's a tough situation if you don't have the laser options available. I do agree. And it's not an innocent disease. We do see patients ending up with really worse vision, bad visual acuity over time.
Of course, that's what I'm centering this small minutes to that disease, because it's also the most common thing that we see here in Mexico. And finally, I have seen some new works that I think it's something that maybe will be an open window of opportunity in these cases, as we see in the shortage of Bedpofin. And this is the biophotomodulation, right? Mm-hmm. I have seen some works also from my friend Claudio Vino He has posted and published some of these works in Italy, and I have seen that it works very good. I don't know if we can generalize in all cases. I think there is more research that needs to be going on. But what do you think about this new approach in central serous chorioretinopathy?
The photon biomodulation has been, it's a new treatment modality, and it's still evolving. So in AMD, it does, at the moment, does not seem to find its place, but in CSC, there are positive results, as you mentioned, from Claudio Jovino and his group as well. And we hope that we will start a prospective trial, which needs to be with a control group in order to really see in which cases it can be of benefit. And hopefully, if it would be an option that is widely available and with low risk for the patient, we can only hope that it will add to the treatment options.
Yes, I hope so, because we will have it in Mexico also in this year, I think, in the fall of this year, maybe. So I think it can be a great option. And we can place a little bit of order, about how to treat these patients, because we don't have too many options right now in Mexico. So is there any recent discoveries or innovations in the pachychoroid field that particularly excite you? It's something new that is coming sooner that you can share with us?
Many questions still open, as we didn't have a lot of time, and maybe we do a second part. Because the etiology is still a big question, and I think if we would better understand where this comes from, we might have better options to treat. So one thing is that the group of Camille Boone, they are also looking into genetic changes, and they did see some gene risks or loci that are associated with CSC, which is interesting. Another thing is that the choroidal vessel structure seems to change over time, because people are not born with CSC, right? They do seem to develop at some point those anastomosis and those enlargements of those choroidal vessels, and we still don't know what comes before what. So how does it start and how does it end? So prospective studies are definitely needed. It seems that the scleral thickness has a role there. And one last thing that is exciting, we still don't know exactly where the treatment will find its place, is steroids, which is very surprising, because we all know that a lot of cases are triggered by steroid treatment. However, lately there were some reports that even topical steroid therapy can be of benefit in certain cases. So please do not go ahead and give steroids to the CSC patients. But there are later reports that in certain cases it surprisingly helps. So lots of things we still don't know.
Yes, I just want to mention that I had a case about a patient that has central serous chorioretinopathy, and here in Mexico we have a new drug that it's called, I don't have any financial disclosures, but it's triamcinolone in drops, and it has been developed to penetrate in the inner portions of the eye, in the retina, and it's a good option now, for example, with diabetic macular edema and remaining few cystic changes after you inject the patient, after retinal vein occlusion, and it's a good option. So I think this one can be, maybe in these cases, we need more research, but I think this can be a good option to treat these patients with CSCR, maybe in the next future. Because some doctors have advocated me, give this treatment to your CSCR patients, and no, wait, we don't know if in this patient the steroids can worsen the scenario, right? I have seen this in my clinic also.
Yeah,
and also I hope that, you go ahead.
No, the only patients I have tried it on is on patients with chronic, those peripapillary changes, with a lot of intraretinal cystary changes, and it does help. So again, I would not advocate to start with this, but after you have ruled out neovascularization and have tried anything else, please go and read the papers first and then understand what people did. But it might be an option in certain cases.
Yeah, and I hope that also the artificial intelligence will help us also in the next future to diagnose better.
For everything.
And probably to understand more about the anatomic changes, and maybe have the entity or the cause of these individual patients, diagnose the patients individually. Great, Dina. So 29 minutes and 21 seconds. I think we made it. Of course, we have a lot of more things to discuss. This is a never-ending topic. I think it's very interesting, and we can discuss in any different situations of central serous chorioretinopathy, PCV. You mentioned there is no ending in just 30 minutes. But I think we really enjoyed this small talk. I think I hope the audience will have a better understanding and a better, clear vision of how to manage and approach these patients, especially central serous chorioretinopathy, which is the most common one. And I really appreciate your time. It's an honor for me. Keep learning from you and watching you and talking with you. And I hope to see you soon in Paris and collaborate more in much more works for the rest of the time. Thank you very much.
It was my pleasure, and I'm looking forward to seeing you. And you did a great work, and you keep on doing important work with those lectures, because I think you really help educating people around the world. So
I had a small podcast with Professor Uday Devgan, and I share with him this view that as long as we are alive, we will try to share the information every single day for free. So because we need more prepared doctors around us. We never know when we want to need that treatment too. So I hope to spread more information. Dina.